So the first question really is, I will aim at Nick, because the first question that came in was, how long does it take to learn how to use the technology? And with Nick, we've got the pioneer in the UK, and who has spoken before, I know, on the time it takes to get used to this. And if you could add into that, Nick, what the portability aspects and the other ease of use or whatever, then that would be good if you can say a few words on that as well.
Sure, Paul, thanks. My audio is working, I take it.
Yeah, we can hear you. Yeah.
Okay, so the short answer is, how long does it take to learn to use technology? Is 3 days. Training course in Lecce with the didactic information, and then practicing on patients who, as in Elaine's study, were having a Dexa scan and a R.E.M.S scan side by side. So when I did my training, I did 19 scans, and I had the advantage of having spent 25 years being a spinal surgeon. So that really helps with the anatomy, particularly with the lumbar spine, and particularly with that group of patients that Elaine alluded to with significant degenerative changes, because you need to be able to, if you like, track the spine, recognize that there are deformities in the spine, particularly scoliosis, and then learn how to use the R.E.M.S machine effectively doing that. Now, in practice, what I did when I set up my service in July 2018 was I dedicated 6 weeks to give anybody who wanted to have a R.E.M.S scan a free scan. And we did 120 scans, and I reckoned I got to about 95% of the limit of my learning curve with that. So I'd done about 140 scans, and I was pretty confident then that I could then offer a service. I think with mentoring and the ability to be trained for a longer period, in the UK that is possible, then I think that could be cut to about 50 or 60 scans. And realistically, that you have a good radiographer or a good clinician who has excellent understanding of anatomy, particularly the spine, the femur is much easier, but particularly the spine, then I think 50 or 60 scans, which realistically you can do in 2 or 3 weeks, is enough to get you to the stage where you're going to be really effective. In terms of portability, I run clinics out of the back of my car effectively. So I travel as far north as Bradford, as far south as Winchester or Pulborough and West Sussex, over to Norfolk, and also into the West Midlands. So I have 2 bags. I have the R.E.M.S machine, which is now the new version, which is the integrated touch PC, with the new software, the Fragility score software. That's great. One fairly heavy suitcase. I mean, it's what, 17 or 18 kilograms, but it's fine. It sort of it puts a bit of pressure through my spine, it keeps my bone density up. And then 1 bag for gel and scales and stadiometer and various other bits and pieces. So it's 2 bags and a lunchbox, and then I can go anywhere I like, as long as they've got a plinth and a Wi-Fi. I can then run that, and I demonstrate the results immediately to the patient on my laptop, and then we just email the results to them, secure email, and that's it. So portability is excellent. Acceptability is really, really good. Patients like the idea that we go local, we bring to them the technology rather than having to go to somebody to wait to then have a scan and then wait while the GP gets the results, or they go to see Elaine in the clinic and you have to wait for that 3-4 weeks, whatever it is. They like the ability to have the results immediately. So realistically, the technology is very usable. You need a clinical acumen, obviously, but it's very portable and accessible, and it's very much liked by the patients.
Thank you. And just keeping you in the chair for one more question here. Could the patient's positioning affect the R.E.M.S exam output?
Yeah, particularly with the femur, yes, because with the femur, when you position them, the key to position for R.E.M.S is to do exactly the same every single time. So they lie down and you put the legs just shoulder width and externally rotate the left leg. So you're then presenting the head of the femur, the neck of the femur, trochanter in a way that the REMS will recognize. So if you get that wrong, it's fine, because what will happen is you won't get a result. Because the nice thing about REMS is if you don't get the right acquisition, REMS said, sorry, they're not interested, and doesn't give you results. So there's no post-processing error, which is great. So get the right acquisition and you will get the right result, but that does depend upon predictable positioning. With the spine, the only problems I've had with positioning are with people with a high BMI, and that can then represent a bit of a problem. So you do need to be a little careful. With people with normal range BMIs up to 30, 35, it's, even the sort of slightly chunkier guys, it's not a problem. But if you've got a BMI of 50, then it is a struggle.
Thank you. Let's go move on. So then I think a question maybe for both of you. I mean, do you think this technology can be useful in monitoring dosage response of osteoporotic medications already after 6 months?
I'll defer to Elaine first. I have my own opinion.
Well, I think my answer to that would be a fantastic question, and actually would be a great study to do. I suppose from a clinical point of view, the real interest in that is that one of the other hot topics, if you like, for osteoporosis is compliance and adherence to medication. So anything that we can do to give some positive feedback to a patient so that they persevere with medication that isn't necessarily going to make them feel different, and if anything could potentially be giving them side effects rather than making them feel better, has to be a good thing. Some kind of evidence that actually a therapy is working is a really powerful thing. Long-term adherence to compliance with any medication is poor, and anti-osteoporosis medication is no different. So do I have evidence that it could be useful at this time? No. Do I think it would be a great area to look at? Absolutely. I think it could be a really fantastic use of this sort of technology. So I look forward to someone setting up the study and coming back with the answer.
I think the precision figures that you got and the ones that have gone previous for the short term anyway are encouraging, and should be encouraging enough to start somebody on that path, shouldn't they? I mean, because with the non-radiation, non-ionizing side, which is the other limiting factor as to how many Dexas people can have in what time period, it is not there. And of course, if we can get a precision error that is below the expected change, then in that time period, then that is where the encouragement comes. So yeah, thank you for that. And Nick, your view?
Yeah, well, I mean, there are two things. One of which is anecdote, and the other is a little bit of science, not matching what Elaine does in her clinic. But the anecdote is that I scanned a lady in 2018 who was a very healthy, fit 42-year-old lady who was premenopausal, and she had osteopenia, which was quite appropriate for her because her BMI was around 20. It was fine. Now, I didn't have the fragility score at that time, so I couldn't tell her what her bone quality was. But we know that with a low BMI, you got to get a low BMD. That's pretty good. I mean, the correlation coefficient for BMD and BMI is fairly close. Anyway, she went off and did high impact Pilates, and in 6 months she improved her bone density, BMD, by 17%. So that was above the minimum clinically detectable difference. Now, to do that, she needs to spend 2 hours a day doing impact exercise, which is not practical, but she was driven. So anecdotally, yes, you can detect change in 6 months, but practically, I don't think it's actually reasonable. And I advise women who, particularly if they've got a threshold level, if they've got a T-score of minus 2.6, which on another day might be minus 2.4, because we're looking at a 0.3 variation on looking at T-scores on the threshold between two different WHO diagnoses. And I say to them, look, do the exercise, get the right supplements going, and come back in a year. Because in a year, we know that the precision is 1.5%, but if you've done well, you might have got 2.5% improvement. So that should be detectable. So I think reality is, in a clinical situation, it's about a year. The other situation I've got is I look after a lot of professional cricketers, and we can identify very quick changes of bone density in professional cricketers. Particularly, I have a particular interest in bone stress injury in the lumbar spine. And when they get shut down, when they've got a bone stress injury, they've always got supernormal bone densities anyway. You know, they're often running at about T-score of plus 1.8, plus 2, plus 2.2. And they drop off very quickly. And Catherine Brooke-Wade and her team at Loughborough showed this. We're using repeated Dexa. But we can use the REMs as a mechanism to avoid Dexa to actually go to the club. So if I went down and scanned all of the fast bowlers at Worcestershire County Cricket Club at the back end of 2018, just put them all in a room and scanned them all together. And you can do that. It's portable, it's local. So the answer is yes, we can detect within 6 weeks changes with those sort of people, but not, I think, with the general population. So my conclusion is 1 year follow-up is probably about right.
Thank you, Nick. Next question down the list, I think has been answered in your presentation, but we will ask: do you use REMS technology on any pregnant women?
I haven't used it to date at all. I think there has been a study recently. I'm looking to you, Paul. I thought I saw something that suggested that, and maybe an abstract that suggested that people were thinking about using that technology. So I haven't used it, but I think it is an area of interest, and I think some people may be looking at it.
I mean, there's no reason not to with the non-ionizing. Yes, I don't know whether the spine would be a problem, but certainly the hip wouldn't be a problem. And in fact, I have actually demoed on a pregnant woman. So yeah, that's okay. A sample of one, so I can't really comment on that.
I've got a sample of one as well, Paul, and that is a lady who had a previous pregnancy, and she had regional osteoporosis of the left femur. And so that was quite safe. But she was more than 18 weeks pregnant. By the time you get to 18, 20 weeks of pregnancy, the fundus of the uterus is up by the umbilicus, and realistically it's overlying the L3 and L4, so you can't do that. Early stage pregnancy below 12 weeks, you're probably okay for the spine, but beyond 18 weeks, you're not.
Yep. Okay. One question: how do you define REMs in terms of precision and repeatability? I think that was the answers were in the presentations, I think. But any other comments on that?
I didn't really speak about repeatability. I mean, I assume the question is getting at, if you get the same person to perform serial scans, how repeatable is that measure? Nick, probably you're better placed to speak to that, because you'll have probably numbers.
So we did exactly this calculation on the first 700 scans that we did. And the answer is that the intra-operative variation is around about 1.2%. And the inter-operative variation, depending on the nature of the clinician doing it, is about 1.8%. So less than 2% on both. So I think the answer is highly precise and repeatable.
Thank you. A question from across the pond: are you using fragility score clinically?
Absolutely, every single case. And the reason for that is because it measures, I mean, sorry, jumping in, Elaine. I don't know whether are you using the fragility score, Elaine?
No, I mean, we were delighted to take part in the study, but no, we're not using fragility score at the moment.
So given that fragility score is the equivalent of the trabecular bone score, therefore is looking at the microarchitecture, and the bone mineral density is looking at mineralization. My advice to patients is, look, one tells you about how much your diet and your ability to get calcium into the system is, how well that's working. So that talks whole about functional medicine. We have a big discussion about nutrition. but the fragility score tells me what you're doing in terms of impact loading of your bone, and how well your bones are responding to that, because that's just straightforward Wolff's law. So in simple terms, when I'm advising patients, I use the two very definitely, because we see patients with osteopenia, maybe minus 2.3, minus 2.4, but they will have a fragility score well in the green zone, maybe down around 20%. So they've got reasonably mineralized bone, but they've got tough bone. And that really, it answers your question you posed, Elaine, earlier. And that is, we know that there are women who have osteopenia. The highest number of women who fracture have actually got osteopenia, not osteoporosis, because the large numbers of them. Well, why is that? And now the fragility score is available, which the trabecular bone score being the equivalent of, we can understand that if they actually have fragility, but reasonable BMD, that may be the reason underlying their propensity to fracture.
Just got some stuff hot in off the press from Italy. Yeah, there's male studies. There's some scientific material and studies being discussed and submitted for international congress on about 2,000 male subjects, but it's yet to be published. And on the pregnant women, the University of Parma with Professor Guy has published a study that reveals BMD loss of about 8% during pregnancy. So that's a study that's been done with REMs on pregnant women. So there is some data out there. Yeah. So that's a recap there.
Because traditionally the number of 5% loss per pregnancy sticks in my mind.
Mm. Okay, yeah,
that's the right range, isn't it?
Yeah, yeah. Some age-related tendency higher in younger mothers, apparently. They've come out of that study. Yeah, yeah. So yeah, that was that one.
It does clear children are parasites from the very moment they're conceived.
Doesn't it though?
Yes. Yes, that's just what my stepdaughter called our latest granddaughter when she was inside her still. Yes, parasite was that word she used. Yeah.
But much loved.
But much loved, yes, of course. Right. Going on. Are we still okay, you two, for time? Yeah. Yeah.
Fine.
Yeah. Can we really expect to get additional information in patients with spine abnormalities or aortal calcification, given nearly the same BMD values as compared to Dexa in the complete patient set? Again, I'm not sure if I understand the question too well. I don't know.
Well, if you take it into two stages, one spine abnormality, and the answer is that Elaine answered that question, or maybe you did, Paul, because the R.E.M.S system is excluding the abnormal signal in its curve matching. So therefore, the frequency curves that it's generating will only include the region of interest in that 1.5 centimeters deep to the anterior cortex, and it will exclude vertebral osteophytes, rim osteophytes, etc., in exactly the same way that it can then exclude abnormal data from a modest osteoporotic fracture, say a genetic type 2 fracture, although I think it would be struggling with the genetic type 3. With aortic calcification, unless it's really dense calcification, because you set the acquisition parameters to the depth that you need, so it's actually the vertebral body as opposed to the few flecks of calcification in the aorta, really with a little bit of aortic calcification, I would be surprised if it was going to confound the system.
Next question in. Smallest detectable difference is better in REMS than Dexa. Could you please guide us on the real advantage of it? I can take this offline with Ishan if need be, if the answer is too long.
Elaine, that's for you, isn't it? That's you manage these people in clinic.
I mean, my answer from a clinical standpoint would be, to give you the comparison with Dexa, if I'm seeing someone who is having repeated Dexas, obviously, the minimum duration that you have to wait before the second scan is a year because of the error on the machine. So it's not possible to give, you know, any real indication of whether a therapy is actually having benefit at less than a year. I mean, it comes back to my point about adherence and compliance. So for me, the advantage of having something that gives you an indication of whether a therapy is working sooner is that actually then that gives you feedback to the patient sooner, and that encourages them to persist with something. I mean, Nick, you were probably, you know, you can give a much more elegant sort of technological answer to that, but that from a clinical standpoint, that to me is the advantage of that.
Yeah, we'll take that in a technical discussion if the questioner wants to ask me directly, via email.
Data.
Yeah, that would be.
Paul, can I jump in? You missed one question from Abbas Ismail.
Yeah,
I'm leaving that to the last. That's
All right, well, as long as we come back to it.
That's the bang at the end of the meeting. Okay. I'm coming back to it. Yes, yeah. So yeah, there's another question about pregnant women, but I mean, no, there hasn't been any work done at the moment on connecting with the health of the fetus, as far as we understand. The only information we have is the one study on the actual mother's health rather than the fetal health. Heel ultrasound technique failed to detect changes in BMD with osteoporosis medication. Lunar tool nearly 20 years ago. Yes, and that is why in my main presentation that I gave last time is there was a big cross through heel ultrasound and QUS, because REMS is not QUS. It is a totally different technique. And yes, and Elaine said about it in her presentation, in the fact that yes, heel QUS is very good at fracture, is as good as Dexa at fracture prediction, and screening out people with high risk of fracture, because you have a bone strength element in the measurement, but it does not measure BMD. It cannot directly measure BMD, so you cannot use it for monitoring treatment. No. So I will answer that one. Can one perform REMs not only trams and transabdominal, but from lateral backside? No, it is only through, because you have to have a clear path through to the bone. I think both panelists would agree with that. You can't go through bone with an ultrasound to measure a bone laying beneath it, which would stop that happening.
Well, the lateral approach is not an unreasonable question, Paul, because if you go laterally in the flank, you can see.
All right, sorry, yeah, it's lateral, not.
Yeah. But actually, because the machine is set up in such a way that it's expecting to get the acquisition from the front, and that is what it's looking for, you wouldn't get an acquisition match, and so the likelihood of being able to do that is low. Secondly, the acoustic window from the side between the 12th rib and the pelvis is really quite narrow, and you probably would not. I mean, the 12th and 11th ribs overlie in a lateral projection, L1 and part of L2, so you wouldn't be able to see them. So the answer is the biggest window is transabdominally with the patient supine.
And that is why Dexa does it that way as well.
Yep.
How large is the reliability of the literature concerning REMs in males? Well, nothing has been published yet, so we can't really comment on that one. Would you recommend you replace Dexa with REMs, with a REMs?
Of course.
Thank you.
Except
I won't ask the scientist, I'll ask the doctor. Yeah.
Well, of course, hang on a second. Every single hospital in the UK pretty much has got a Dexa machine. And the machines are in their pool because you used to sell them. Yeah. So the legacy technology is going to stop you getting effectively REMs into hospitals unless it's into a unit like Elaine's, where you're doing some comparative research, etc. The real value of REMs is outside of hospitals. So in some respects, it doesn't compete necessarily with Dexa, because actually, if we're going local, if we're taking the technology to people rather than coming to the technology, then it wins hands down, because Dexa can't do that. So I think that the growth in this technology is actually going to be in imaginative ways to try to go to places where you want to identify what bone health is doing. So I can imagine, for instance, once we get rid of all this silly pandemic stuff, going into care homes and actually scanning women in care homes. So you have a plinth and they get up on the plinth and you just do the scans there and then. And instead of then having to come to the hospital and having to go on an ambulance and having to wait and all the other bits and pieces, go to them. I've always been thought that localism was a great way to run medicine, and this is a technology that allows that in spades.
Yeah, and with the pandemic, if we take the other side of the pandemic, then being able to open up the services before people can travel to hospital, and en masse will help as well. I think,
we can be much more COVID sure in a small clinic where there aren't lots of people, and where you're not running the risk of them picking up a bug, because we know that hospitals are dangerous places.
Yeah, so there we go. I think we've covered most others, that are still out there. So now the big question, the ending question from Abbas's mail, I'm in Stockport there. Are we at the stage now to say that Dexa is no longer the gold standard and REMS is equivalent, or are we not quite there yet?
Elaine first.
Evening, Abbas. If it's the Abbas Ishmael I know, hello. Nice to hear from you. I wouldn't say they're equivalent. What I would say is that it's great to have an emerging technology that shows such promise, and I can see a lot of ways that it will be very, very useful in the management of osteoporosis, the investigation and management. Could I say that it's the gold standard? No. I'd have to say, given all the sort of the evidence that we have for Dexa, it remains the gold standard. But as I pointed out in my talk, it is not perfect. There are limitations with it, and I think it's important that we continue to look for technology that can do better. And I think what we're seeing from REMS is really encouraging, and there are real ways that actually, and Nick's just said, there are lots of populations where actually this technology may be particularly useful. But for me personally, I want to just acquire as many tools as I possibly can do. So I would like to keep my Dexa and my high-res PQCT and my REMS machine and everything else, because I think they all have a place. And for certain, study groups, some are obviously better suited than others, in the same way that I'm very grateful for the range of osteoporosis medications that we have, because actually different things suit different people, and choice is a wonderful thing. So, Nick, you might have a different view.
No, I don't actually, Elaine. I actually have exactly the same view, and that is that I think that while we have a denominator that is relatively small for Dexa, for REMS, sorry, against the huge denominator for Dexa, I mean, I don't know how many patients have been in the studies over the last 30 years of all the Dexa scans, but it's got to be hundreds of thousands, if not millions, whatever it is. I mean, we've got a few thousand for REMS right now. Every paper that adds to that then adds to the evidence base, which is fine. But really, to be a gold standard, you have to have a very, very high level of evidence, which we're not there yet. So Abbas, I agree that it's not there yet. What I would say is that there's a difference between gold standard Dexa and real world Dexa. And we know that from the Society of Clinical Densitometry that there is a very big push, and there has been from the Royal Osteoporosis Society, to get accuracy in Dexa, particularly in the post-processing, which is, I think, it's real Achilles heel. And I see that quite frequently, because women come to me with particularly major discordances between their T-scores, and they don't understand how that occurs. So I think actually in reality, if all of Dexa scans were carried out at the gold standard equivalent level, then it would stand up and say it's still gold standard. But real world Dexa and REMs are very close together.
Thank you, Nick. I think now all it is for me to say is thank you both very much for your time and your words, and keep up the good work.
You know, there's one more question, Paul.
Is that all right? If you've seen it, you ask it.
Dennison has said, hello, and thanks for the great webinar. Is there any possibility that REMS technology will scan other parts of the body like the Achilles heel or the forearm and give us a report of bone health in those parts in the future? Do you know what Echolight are doing?
I know from the very beginning of my time there, the forearm is on an agenda. How high up the agenda, I don't know. It gets lower with the fact because forearm is used in those sites that you can't scan the spine because of degenerative change. You've got bilateral hip replacement. You've got a site that you can measure that is which is within the WHO classification for osteoporosis. That is the use of forearm. With REMs, it's now going more like, well, we can scan the spine even if we haven't got any hip or we've got a bad spine, we can still get some measurement out of that spine. So I don't think the forearm will be high on the agenda. The other aspects will be that are on the agenda for development are arthritis, the cartilage measurement, and body composition, advancing that, and sarcopenia for muscle. So really, they are the next generation of developments. And again, commercially, if REMS isn't selling, if Echolight isn't selling because of there's no forearm on it, then forearm will be developed because that's the way Dexa went. But it has to be a commercial need, for that.
In that wish list,
Mm-hmm.
my number one, because I see it in my clinic, is sarcopenia.
Yeah.
If I could offer the postmenopausal woman a bone density, bone fragility, and a sarcopenia result, I think that would go an awful long way to help to manage a lot of women in the community, because we know that bone density and sarcopenia absolutely go together in terms of falls and then fracture prevention. And this, I think, would be really very, very helpful measurement. And if that's the next generation, then I'll buy into that.
Well, I can assure you, your words have got onto the ears of the top men and women in Echolight, because they are listening in and they're listening to your words. So that will have got to them. Yes. Yeah. Okay. Well, thanks again, both of you. Very, very, very good. And we'll see you next time.
Take care. Bye-bye.
Bye.